Things are changing quickly in the obesity pharmacotherapy landscape. This is a spring 2024 update on the options, the medication options that are currently available in Canada for the management of obesity. Please be clear that none of this is medical advice. This is for educational purposes only for my BPK 417 class. I'm not here to recommend any drugs. I'm also not here to deter anyone from taking these drugs. I just want to give you an overview of what's available, how effective they are, what are some of the trials that have gone into these drugs, and what some of their side effects and considerations are as well. So in this unit, what I want to do is go over the 5 Health Canada approved medications for the management of obesity. This is just an organizer chart. I'm going to start this unit by talking about the tides: semaglutide, liraglutide, and tirzepatide. Semaglutide, you've probably heard of it as Ozempic. That's the diabetes version, lower dose diabetes version. The higher dose obesity version, both of these are injected, is called Wegovy. There's also a once daily oral tablet, that's semaglutide, that's called brand name Rybelsus. There's liraglutide, which is very similar to semaglutide, but liraglutide is injected daily, goes by the brand name of Saxenda, and it doesn't have the same level of weight loss effects and other effects that semaglutide does. A newer version of these tides as well is tirzepatide, which is a dual receptor agonist, both GLP-1 and GIP. Notice that the first 3, GLP-1 receptor agonist, GLP-1 receptor agonist, GLP-1 receptor agonist, and GIP receptor agonist. What do these do? All 3 of these drugs, they help to mimic what's it called, the incretin effect. And the incretin effect is the effect of these 2 naturally occurring peptides, GLP-1 and GIP, which when we eat carbs, basically our intestinal cells tend to release these 2 peptides and that have various target tissues that basically tell the body, hey, we've eaten, start to change a bunch of physiological effects to mimic the effect that we've eaten, including increasing insulin, which lowers blood sugar, decreasing gastric emptying, as in like, I don't need anything more from the stomach, so stop emptying the stomach, keep the stomach feeling full, and then a decrease in appetite through some hypothalamic circuits. Okay, so all of these drugs are very effective at lowering weight, mainly by lowering our desire to eat. Okay, they range in price though from about $350 to $450 a month Canadian. In the States, they can be upward of $1,000 US, which is about $1,300 Canadian. The other main, and sorry I'm rushing, but there's so much to cover today. The other main obesity medication approved in Canada goes by the brand name Contrave, and Contrave is again, dual drug. It's got bupropion, which is a norepinephrine dopamine reuptake inhibitor, and it has naltrexone, which is a mu-opioid receptor antagonist. What does that mean? That they have targets around some reward center pathways. And remember, the reward center, that's the thing that makes us like seek out rewards. It makes us highly motivated to go and be very focused on seeking out a reward, like a food reward. Okay, this one is cheaper, though its effects on weight tend to be not as strong as semaglutide and tirzepatide. And then the last approved obesity drug is the one that's been approved for the longest, since 1999, and this one works in a very different way as the other ones. This isn't about appetite. This is about, well, I've already eaten, and when you eat some fat, usually in your diet, but this drug blocks the action of pancreatic and gastric lipases. Lipases are needed to break down fat, because if you can't break something down, you can't absorb it. Okay, so basically these block that the action of that enzyme. So we can't break down fat, we absorb less fat. Fat has 9 kilocalories per gram. We're absorbing less kilocalories. And so our energy intake, our caloric intake, goes down accordingly. So those are the 5 approved obesity medications. I should say, just as a side note, that tirzepatide, it is not currently approved in Canada for the management of obesity. It is approved as a type 2 diabetes medication called Mounjaro. The obesity version, the higher dose obesity version, is called Zepbound, which which is not currently approved in Canada for the management of obesity, but I see that happening soon. Okay, so let's start with the first three, the tides, semaglutide, liraglutide, and tirzepatide, and all of these work on this kind of incretin pathway. So incretins, GLP-1, glucagon-like peptide 1, and then GIP, I have such a hard time saying this one, glucose-dependent insulinotropic polypeptide. These two are incretins, and the incretin effect means that like when I eat glucose, I see 2 to 3-fold higher like insulin response than when I inject glucose, which means that there's something happening in the digestive tract once it receives glucose that's causing this higher insulin response. That's GLP-1 and that's GIP, these two incretins. Okay, so these incretins have been well established for a long time to be associated, well, if they're increasing insulin, they're lowering blood glucose. You can understand why they've been studied for the management of type 2 diabetes. However, one of the side effects of this incretin effect and these hormones, both endogenous, like naturally occurring, and exogenous, like when we take these drugs from another source, is that we do see an improvement in glucose management. We also see an improvement in cardiovascular outcomes, which I'll go over in a second, and we see a strong appetite-reducing effect. So, which makes sense, because if these drugs are mimicking these natural hormones we have in our body that tell us when there's food in our digestive tract, when there's carbs in our digestive tract, it makes sense that they also are telling the brain, hey, we have food here, eat less. So of the GLP-1 receptor agonists that are currently approved in Canada, the first one to be approved, which was in 2015, was something called the liraglutide, which goes by the brand name Saxenda. This one is injected once daily, and like I mentioned, it was originally marketed as a diabetes drug, but it also had these effects on cardiovascular markers, as well as on appetite-related factors like slowing gastric emptying and in particular decreasing appetite. We're going to see a common theme around these tides, these incretins, in that their main side effects are gastrointestinal related. One of the main reasons people discontinue their use is because of strong nausea, vomiting, and other gastrointestinal issues that they experience, which are typically stronger at the start, but that can be very severe in some people. Some people have no side effects whatsoever, but some people have really strong side effects to these. Those are the main ones. I just wanted to kind of put this breakdown of how these studies are conducted so you can get a sense for how these interventions, these randomized control trials tend to happen. So notice that lifestyle intervention is a big part of these interventions as well, these clinical trials. That's going to be similar for every drug we talk about today, that there is usually a 500 kilocalorie caloric deficit that is recommended, as well as physical activity, and there's usually some sort of like nutritional counseling that happens as well. There's usually a run-in period, a screening and a run-in period where the people are not on any kind of medication, and then in this trial they randomized people to basically higher doses of this liraglutide, and they compared it with Orlistat, which was that fat blocker drug that I'll talk about a bit later as well. So this was a 2-year trial, and what they found is at the end of year 1 and overall at the end of year 2 that there was a higher overall weight change in kilograms, so about a 5.3 kilogram change in weight on average in the higher dose liraglutide group compared to both Orlistat and compared to placebo as well. We also saw with the higher doses, there was a higher amount of people that lost at least 5% of their body weight, and fewer that lost about 10% of their body weight, which is often how these results are reported too. They also saw a number of cardiovascular improvements with higher doses of liraglutide. So we see a decrease in systolic blood pressure. We also see a decrease in the amount of people with type 1 with prediabetes, and a decrease in individuals at the end of year 1 that had the metabolic syndrome. We also saw a decrease in triglycerides and LDL cholesterol on these higher doses of liraglutide. So these studies are also like proof of concept that the GLP-1 receptor agonists have an effect on various cardiovascular outcomes, but also on weight management. As I mentioned earlier, the main side effects, adverse effects that we see on liraglutide are gastrointestinal in nature: constipation, diarrhea, nausea. These are reasons why people don't tolerate the medication well. It's one of the reasons I probably would never take these medications, because I already have a very sensitive digestive tract, and I'm sure that they would not help. But it really depends on the individual, and some people have no side effects whatsoever. That said, there were some other kind of cases, you can read through this as some of the other cases that showed up as far as side effects go, and I'll get into more when we talk about the semaglutide. These drugs are not for everyone, as I keep saying, and it really is important that if someone is considering taking these weight loss medications, that there is a history, a medical history that is run. You consult with the patient as to what the best approach is for them, but there are considerations to the use of this drug that we can't just put aside. Okay, so that brings us to semaglutide. So that's the big one these days that people hear a lot about. Again, GLP-1 receptor agonist, again, increases insulin, reduces blood glucose, slows gastric emptying, and the big thing is decreases appetite. And you'll actually hear people talk about these drugs, and one of the things you often hear people say is that it decreases the food noise. So again, these incretins, they're naturally occurring hormones, but we see less of a response, less of this incretin effect in individuals with type 2 diabetes and with obesity. So what we're giving these people is kind of what a lot of people already have, which is the messaging to stop eating once you've eaten enough. So when people don't have that messaging to kind of stop eating, it can be associated with more of this food noise, as in I need to eat, I need to get something, I need to get something, give me food, give me food. And we do see that a lot of people report a decrease in that desire to eat because of the effects of this drug. The semaglutide randomized control clinical trials are known collectively as the STEP trials, and there's various STEP trials, and they're still going on. Now we're looking at different populations. Now we're looking at semaglutide for osteoarthritis and other things as well. But I'll go over some of the kind of the main semaglutide STEP trials that have led to it being approved and our knowledge of what this medication can do. And just a side note, this is from February 5th, 2024. I'm shooting this video March 25th, 2024, and Wegovy, the obesity management version of semaglutide, is still having availability issues. Just to say that although these drugs exist for the management of obesity and diabetes, they're not necessarily always available, although I see that changing. Step one was really do these 2.4 milligram weekly injection of semaglutide. Does it have, plus lifestyle intervention, does it have an effect on weight loss? And you can see here that week since randomizations, 68-week trial, we saw a significant decrease over placebo in weight of the participants, which I should mention are 3/4 of which were female, 3/4 of which were white. That is something to keep in mind when we're looking at these results. But anyways, we did see a significant reduction in weight in these groups, and we saw a larger reduction in weight than we saw under the liraglutide trials. Okay, so in these trials, we saw 86% of participants had more than 5% weight loss, and 70% of people lost more than 10% of the weight. 50% of people lost more than 15% of their weight. So these were the highest numbers we had seen at this point for these weight loss medications, and that's why people went nuts when these results were originally presented. These semaglutide trials also showed a number of improvements in other endpoints beyond weight, although that was the main focus of these studies. We also saw improvements in systolic blood pressure over control. We also saw improvements in glycated hemoglobin, which suggests an improvement in glucose management. We also saw dramatic improvements in fasting blood glucose and diastolic blood pressure as well. And although those weren't the primary endpoints of the study, it again suggests that there are metabolic benefits of taking these medications as well, and they can help to manage type 2 diabetes and perhaps have improvements in cardiovascular factors as well. And we're going to look at that in another study as well. As we know, though, all medications have side effects, and semaglutide is no exception. I wanted to highlight some of the adverse effects from that original STEP trial, which had the highest level of participants, over 1,900 participants. So what we found in the semaglutide trials is that about 90% of people had an adverse effect. That said, that was actually kind of similar to what we saw in the placebo group, but there were some areas of attention that we did see kind of a bigger deal with semaglutide versus placebo. I do want to mention before I move on that there was one fatal event in the semaglutide trial. We actually also saw that in the placebo trial as well, independent reviews of this one, and there was a fatal event in another trial as well. Independent reviews of those trials argued that it was not related to the drug itself, but it is always worth paying attention to a fatal event as well. I don't want to dismiss it either. The majority of side effects that we saw, or adverse effects that we saw with these semaglutide medications, really did focus on gastrointestinal issues. So nausea, diarrhea, vomiting, constipation, headaches, these are things that were more common in the semaglutide group as opposed to in the placebo group. I'm not here to recommend these drugs. I'm not here to not recommend these drugs. What I'm here to say is that every case is different, and that it's really important for people to be aware of the potential adverse effects if they are considering these drugs. And this video is not comprehensive by any means, but it again just shows that like these drugs are not for everyone. Although some people have zero side effects, and the only side effect they have are the like improvements in cardiovascular health and the improvements in weight as well. The step 4 study focused on, well, okay, these people went through the semaglutide trial. What happens when they stop taking the drug? And we found that after the 20-week run-in where all participants were on the semaglutide, we saw that in individuals that kept taking semaglutide, we saw further reductions in weight till about just over a year as we see the biggest reductions in weight, and then we do see a bit of a trend either plateauing or a little bit maybe upwards as well, slightly. But in those that discontinued use, we did see an increase in weight kind of immediately after discontinued use. So step 4 trials, these are kind of the earliest trials to show that like you need to keep taking the medication in order for it to work, which is part of the conversation around these semaglutides as well. And something else this trial shows, and you can kind of look at all your p-values to see which of these effects were significant, statistically significant. We do find that all those kind of improvements in secondary endpoints and supportive secondary endpoints, like kind of cardiovascular related endpoints, that for these individuals, the improvements that semaglutide offered, they kind of went away when that individual switched to placebo. And then step 5 trial, this kind of looked at could semaglutide be used more long-term in individuals with overweight and obesity. And again, we saw greater obvious reductions in weight, percent change in body weight compared to placebo. We saw that way more significant and maintained in the semaglutide group as opposed to the placebo group. And in the semaglutide group, more than 77% of individuals were able to maintain that weight loss, whereas only 34% of individuals in the placebo group, who also underwent that lifestyle intervention part, were able to see that more than 5% reduction in body weight. I thought this was interesting that from the study results, so I've put it in here as well. Of interest, while the vast majority of participants receiving semaglutide, 2.4 milligrams, lost weight at the end of step 5, a small percentage of participants experience weight gain. So interesting. It's so interesting, and we see this kind of in every obesity treatment program, that the majority of it kind of looks like this. It goes like that, and then we see a trickle up, especially if treatment stops or the thing, after kind of its most effective state. We do see weight trickle up to varying degrees. But always we see, no matter what type of intervention there are some people that tend to gain weight on the intervention, and it is not fully understood why. But again, it speaks to the complexity of weight management. And that said, I think it can be very frustrating for someone who maybe spends so much money to go on this medication and has so much hopes for this medication, and they see kind of the opposite effect. So it's important to mention that for these medications to work, a caloric deficit has to be achieved. And I don't know if you know who Tracy Morgan is, but he was just on one of the late night shows, and he said he gained 40 pounds on Ozempic. right? The lower dose diabetes version of this drug. And I don't know if it was just a joke or if it was true, but what he said is he out-ate Ozempic. And you can out-eat this drug. Like, if you are not listening to the signals that the drug is telling you, you can still eat more, right? And get into a caloric surplus. So it's important to remember that a caloric deficit has to be achieved and maintained in order for these medications to work. You know, it's a 2-year trial, and we're still kind of in the it's not that we're only starting to research these drugs, we've been researching them for a long time, but we're kind of in the beginnings of kind of widespread adoption of these anti-obesity GLP-1, GIP receptor agonist use. And I think it's always important to proceed with caution and to really, monitor dose, monitor outcomes, monitor other potential effects that this drug has. And I guess we're really going to see what the future holds for this. But I'm always, I think these clinical trials were well run. They were run around the world in a number of different clinics over a number of years, and we keep seeing kind of similar results. So to say it's unstudied or unvetted is not true. That said, I always like to keep a door open for like what might we find about these drugs in the future. But right now they seem to be very effective for weight loss and improvement in cardiovascular outcomes as well. To that end, another kind of major study that came out a little more recently in 2023 was around the cardiovascular outcomes in obesity in people that don't have diabetes when they are taking semaglutide over a 4-year period. And the results of this study are kind of summarized in this graphical abstract, but what's kind of the main outcome that they found is that there were fewer deaths from cardiovascular causes in the semaglutide group versus the placebo group. And again, adding a little bit more evidence to these drugs are not just important for weight management, but they're also potentially life-saving and potentially like really important for cardiovascular health and diabetes related health too. Okay. And then one last incretin. Most of this conversation is going to be on incretins today, but one last GLP receptor agonist. That's actually a dual agonist. This tirzepatide not only targets the GLP-1 receptor, but it also targets the GIP receptor as well. And this kind of dual agonist approach works in a similar way. Increases insulin, reduces blood sugar, slows gastric emptying, decreases appetite. But the weight-reducing effects seem to be even more pronounced with these tirzepatide drugs compared to the semaglutide. So weight loss in like the 18 to 20% range with these tirzepatides compared to about 12 to 15% range with the semaglutide. So I can see this drug having a huge uptake as well. Remember, only Mounjaro is approved in Canada, and it's only approved as a type 2 diabetes medication. The obesity version of this drug, Zepbound, is not yet approved in Canada, but like I said, if Mounjaro is approved, I expect Zepbound to be approved as well. And this again is just a summary graphical aspect of the kind of main tirzepatide trial that found significant weight loss in individuals with obesity. And again, unsurprisingly, we see with higher doses, we see higher levels of mean weight change. This is percent change. We saw up to like 20% change with these tirzepatide medications. And we saw even higher amounts of people that lost more than 5% of the body weight with tirzepatides. And we do notice that the gastrointestinal effects are similar to what we saw with liraglutide, with semaglutide as well: nausea, diarrhea, and constipation. And I don't want to just like breeze over those as well, because those are very serious complications, especially maybe in someone that already had gastrointestinal issues. And in some people, they're just way too strong, these issues, that they will discontinue use. So to summarize all this conversation about the incretins, semaglutide, liraglutide, tirzepatide, their use has shown the most pronounced amount of weight loss we've seen with these obesity-related medications, kind of in the new era of obesity-related medications. And again, with those improvements in weight, we also see improvements in inflammation-related markers, which I didn't talk much about, but we do see reductions like in C-reactive protein, for instance. But also we see improvements in cardiovascular-related outcomes as well. So like there's a lot of positivity around these drugs. That said, they're not for everyone. Adverse side effects do occur in some people more than others. nausea, vomiting, diarrhea, gastrointestinal distress in general is common. It tends to get better over time, but it is worth noting. And some people are really worried about some of the other potential side effects as well. And that's why it's so important to have that medical history of the person and consider that with the potential contraindications as well. Okay. That said, all these improvements, they only really are sustained for the length of the taking of the drug, which is an issue right now because there is significant availability issues. Even if they are like fully stocked at the pharmacy, they're very expensive. They're very expensive, and like $350 to $450 Canadian, about $5,000 a year Canadian, depending on where you buy them. Drugs are always cheaper at Costco, just as a side note. And in the US, they're like more than $1,000 US a year. And then that again speaks to equity issues. We see higher levels of overweight and obesity in a lot of equity deserving groups. Are we going to see further and further health disparities amongst people that can afford these medications versus people that can't? So speaking to that point, this is a study that was published in 2021 before like tirzepatide was approved in Canada, before semaglutide was approved in Canada, and it just looked at like diabetes medications and the disparity in their usage amongst different populations. And we see, kind of unsurprisingly, that the group that tended to be more likely to start these medications were white, and less often in Black communities and Hispanic communities, and Asian communities as well. So again, and we see higher rates of diabetes and obesity in Hispanic and Black populations. We had these disparities before these drugs were as popular as they are. And now, are we going to see more of these disparities? Some other conversations that are coming up with the use of these incretins and the use of anti-obesity medications is like, who deserves them? Oof, I hate those conversations. I think they're very rooted in weight bias as well. And it's part of us seeing diabetes as a disease, but not obesity as a disease. You'll hear people say like Ozempic is for people with diabetes. I don't agree with that. These medications are for people with diabetes. People with obesity shouldn't be taking similar medications, right? That we definitely know there are comorbidities and effects of both of those diseases on their own that are significant and that can be improved with these medications. Hopefully, I'm hoping that this who deserves it issue will go away when availability becomes less of an issue. Another conversation I've heard is like, is this cheating to take this medication? Cheating what? Cheating, like in what way? I would say the original cheat code is having the right kind of signaling in your body so you never have the strong desire to eat all the time that a lot of individuals with overweight and obesity and diabetes have. The original cheat code is having enough GLP-1, is having enough GIP, is not having leptin resistance, is having proper appetite management and not an overactive reward center. That's the original cheat code. All that these drugs do is help you get the cheat code that a lot of people are born with. So that's my thoughts on the cheating aspect. Another thing to think about is we talk a lot about weight loss, but what about changes in body composition and muscle loss? We do see a lot of muscle loss, lean tissue loss with these medications as well. And that's why recommended resistance training and exercise in general with these medications is also recommended. And then another consideration is the aesthetic question. Like, is it wrong to use these medications for aesthetic reasons? I think maybe yes, if people that need it for health reasons are limited to having it. And I think obesity is a health reason too. I don't know. Like I said, I understand why people want to take this drug for aesthetic reasons, but there are people that really need it for their health. I think, again, when availability becomes less of a problem, those conversations might go away, but it's an interesting one. I did kind of like a pop search on kind of who's taking these drugs and who doesn't. And I don't know who this dude is, but he looks like he's a plastic surgeon, Terry Dubrov. I'm assuming he has some sort of reality show. But what interested me about what he said is, I've tried it. I thought it was amazing. I didn't have that much weight to lose, but I wanted to try it because so many of my patients were on it. I wanted to see what it was like when you're not diabetic and you have only 10 to 15 pounds to lose. How am I doing off Ozempic? I'm overweight and chubby. There's more to love, but I'll tell you something. I'm off of it, but I plan on going back on it when it's appropriate. Like we have a vacation and after that I'll come back. It's like the new Botox Ozempic. I love it. It's so good. I don't know what your opinions are about those statements, but I think it really highlights, like, those with money and those with opportunity have the opportunity to take this medication for, aesthetic weight loss. Well, what about the people without money, without opportunity, and who really need it for medical conditions? Is it going to be, again, furthering health disparities and maybe furthering, maybe judgment against people that are in larger bodies for reasons of things like access and economics and socioeconomic status? So all of those worth talking about. Okay, that was very long-winded to go over all the tides, semaglutide, liraglutide, tirzepatide. I'm going to spend the rest of this time, but not much, the rest of this video going over the two other options for obesity management here in Canada. Bupropion and naltrexone, brand name Contrave, which focuses mainly on the reward center, and then a very different drug called Orlistat, which again blocks pancreatic lipase and gastric lipase, leading to less fat absorption and accordingly less energy intake. And that one's the cheapest one, and like I mentioned earlier, there's also an over-the-counter version of this drug that some people can take, but it's less effective. Okay, so let's start with Orlistat. As I keep saying, it blocks pancreatic and gastric lipase. If the enzyme that's breaking down lipids into chunks that can be absorbed is compromised, right, then we're breaking down less lipids, we're absorbing less lipids. Lipids have 9 kilocalories per gram. We're consuming overall less energy. Okay, that said, this is something that you have to take several times a day. It's a tab capsule that you take several times a day. And if you still consume a lot of fat in the diet, the fat isn't being absorbed, so it comes out. Right? So how does it come out? Sometimes in oily stools. It can also promote fecal incontinence, like the inability to hold it in. For some individuals, gastrointestinal issues are common as well, and flatulence is common. Something else to consider with Orlistat is that fat helps us absorb vitamins. There are certain vitamins that are fat soluble, and that in order for us to absorb those fat soluble vitamins, A, D, E, and K, we need fat in our diet. So it is often recommended for individuals to take a multivitamin when they are taking this medication as well. Okay, we're in the home stretch of obesity medications, and the last one I want to talk about is this naltrexone bupropion combo, which is marketed under the brand name of Contrave. These were both drugs that were independently prescribed for non-obesity conditions. Okay, so naltrexone was originally prescribed for alcohol and opioid dependency, whereas bupropion was originally prescribed for depression and smoking cessation. And they both seem to have effects around the reward pathway. The exact mechanism of action is still unclear, but we do know that individuals that take this combination medication tend to have, again, less of that food noise, less of that reward-driven desire to eat, and accordingly tend to eat fewer calories and lose weight that way. So these studies on naltrexone bupropion combo have been going on for a while. This is a study from the Lancet from 2010. And you can see the blue and the green lines here. They represent naltrexone bupropion at different dosage levels, with a higher dosage level specifically of naltrexone being associated with a higher weight change from baseline at about 7 to 8%, so less than we saw with the tides, in particular semaglutide and tirzepatide. And we also saw decreases, especially with higher levels of that medication, on factors associated with desire to eat, like how hungry did you feel, how full have you felt, how difficult has it been controlling your eating, how difficult has it been to resist any food cravings. And we saw for the higher dosage of naltrexone plus bupropion, we saw an improvement in all those appetite-related measures. But again, adverse effects are something to keep in mind. We do again see higher levels of adverse effects with the 2 levels of naltrexone plus bupropion compared to placebo, though the gastrointestinal effects that were the main kind of issue with these drugs, they were not as severe as we saw with semaglutide and tirzepatide. So these are potentially drugs for individuals that maybe have more kind of a history of dependency related eating or misuse patterns with other drugs. This could be more indicated for them, and it might be more indicated for individuals that are at higher risk for gastrointestinal effects. So this slide actually shows some of the increases in adverse effects that we see with the GLP-1 agonists compared to naltrexone bupropion. Some of these side effects like pancreatitis, like bowel obstruction, even biliary disease, were at least somewhat, if not significantly higher in the GLP-1 receptor agonist groups compared to the bupropion naltrexone groups. So again, like certain people with certain underlying conditions, they're not the right candidates for semaglutides. Maybe naltrexone bupropion is better for them, and again, maybe neither of these options are right for them. So a few take-home messages to leave with is that number one, we are now entering kind of this new world of obesity pharmacology, which I think is changing the conversation around obesity management. Yes, lifestyle modification, behavior change is still our first approach to obesity management, and also with pharmacology and with bariatric surgery, you do need to change your lifestyle with both of these approaches as well. I also think it's really interesting that these drugs, especially the TIDES, the GLP-1 agonists and GIP agonists, and the naltrexone bupropion drugs, they really show that if we can kind of fix the reward pathway and we can fix the appetite pathway, like if we can reduce appetite, then people eat less and the weight falls off, right? And cardiovascular effects are improved. So it really shows how much of a driving force appetite is in obesity. If these drugs work as well as they do, that's telling us that when people don't have them, their appetite is in this pro-eat state for a lot of the time, some people more than others. So I really hope this area helps to highlight the importance of appetite management. So new conversations are emerging, things like health equity. Well, it's been a conversation for a while, but we're having more conversation about that. Access, who deserves these things? Is it cheating? A lot of conversations are happening right now, and conversations that I'd love for you to be a part of from an informed point of view as well. And we'll see what happens as more drugs come down the pipeline and, this becomes kind of the new normal, right, is to have pharmacology as an option for managing obesity. What's going to happen? I don't know. That's the thing about complex systems, is you don't really know what's going to happen until a change happens, and then you see what effect that change has, and then you figure things out from there. So it's really interesting, and hopefully that gives you a good overview of the obesity-related medications here in Canada, if not long-winded, but it's really hard to get through this material quickly. So I will see you in the next unit. Have a good one.